Welcome to the March Facts and Adaptive Trial webinar. And I picked for this month the topic of response adaptive randomization. We have covered it before, but I wanted to revisit it really in the light of the recent conference on response adaptive randomization in Cambridge. Now, for those of you who don't know me, I started working on adaptive trials in 1998, and between about 1998 and 2008, I worked on enabling a number of trials, working on the simulation software, the randomization software, the data collection, and the analysis. And about 10 of these trials I worked on used RAR, and they were in all kinds of indications: stroke, depression, schizophrenia, opioid-induced constipation, diabetes, Alzheimer's, migraine. After 2008, I moved more to concentrate on the development of the FACS software, so became less involved in individual trials. At the Response Adaptive Randomization conference in Cambridge recently, I'm surprised that so much of the academic work in RAR is kind of really focuses on the two-arm trial scenario. The use of RAR in two-arm trials has been criticized for a long time because it loses power, though it does result in the better treatments within the trial. But even that can be argued that that's at the expense of patients not in the trial who are waiting for the treatment after the trial completes. And so actually you're better off just running an efficient one-to-one trial with the maximum power. That does depend on how many of the patient population are actually participating in your trial. The larger the proportion of actual patients in the trial, then the less concerned it is that you might be delaying registration. What a lot of the papers look at is where you use this allocation to not to allocate to the best arm, but to further improve the power. So you can allocate more to the arm with the greater variance. So this could be a continuous endpoint where one arm has got greater than variance than the other. Oftentimes, it's thought that the treatment arm could have an increased variance. Or of course, in the dichotomous endpoint, then the variance depends on the rate, and so you actually, except in the null case, you are going to expect a difference in variance. Although, of course, depending on the different rates, it might mean you're allocating more to control in this case than the treatment arm. But I've always thought that the real advantage of RAR comes in this multi-arm setting. So there's been, over the years, a number of papers that criticized RAR. There are some common people in those papers. There's Cornyn Friedlin, there's Michael Prochard, and there's Peter Thor, although originally Peter Thor was a great proponent of RAR. There's a nice balanced story of the case for and against RAR, written by Dave Robertson and Sophia Villar, who helped organize this conference. And they have this issue in Statistical Science magazine. And they've got a very balanced take on when and whether RAR is an improvement over fixed allocation. I still like to be a little less balanced, so I'm not going to necessarily be even-handed, although I'm going to try and be very fair. There's also a European organization running a small series of webinars on adaptive trials, somewhat like the ones that we ran last year. One of the things they have, which perhaps we should have done and didn't, is they have a discussion board, so you can publicly ask questions and everyone can see the answers. And there's been some questions about response adaptive randomization, and there seems to be an expectation or a presumption that doing RAR is going to inflate type 1 error. And in this multi-arm setting where what you're doing is trying to find the best arm, actually the opposite is true. And I'm going to certainly demonstrate that in this talk, and to an extent, I hope that the demonstration is kind of sufficiently concrete and abstract that it's effectively a proof that RAR reduces type 1 error in this multi-arm setting. You also note that I'm also saying that where we want to find the arm with the best response, if you were doing a trial where you're testing multiple arms and they're all different treatments, and you want to test each of the arms as to whether it's effective or not, then it's kind of like you're doing multiple two-arm trials, but you happen to have a common control arm, and they're equal allocation, or rather one-to-one allocation in the treatments, and root K, where K is the number of arms, allocation to control, is almost certainly likely to give you the most power. So I'm definitely talking about the setting where we don't want to test all arms equally. What we want to do is to find the best arm and prove that is better than control if it exists. And so I'm going to do this talk into two parts. I'm going to turn to facts for the second part. But for the first part, I wanted to try and simulate the effect of response adaptive randomization as simply as possible, in a way that it's kind of clear that all that's going on is response adaptive randomization. There's absolutely nothing else that's kind of can be going on under the hood. And so one of the slight problems with facts is, maybe it seems a little bit like a black box. And because you're doing Bayesian stuff and it's doing a more detailed simulation of the trial, perhaps there's that people might be a little bit skeptical still that there might just be something else that's contributing to whatever we see. But so I've just written this extremely simple piece of R code to just simulate the response of the effective response adaptive randomization. I want to look at a number of things that people worry about RAR. So does RAR inflate type 1 error? Does RAR introduce bias in the estimate of the response? Does RAR introduce a risk that we're going to pick the wrong arm? And then another thing that perhaps people don't think about too much, but as a result of RAR, how many subjects will we have actually allocated to the arm that we eventually choose? I'm going to compare that a little bit briefly to arm selection. So instead of doing RAR, what happens if we have our multiple arms, have a point at which we select one of them, and then just carry that one forward to the end? So that's a nice, straightforward frequent list design. And then finally, when we switch to facts, I'm going to look at a number of other things that are kind of easier to do in facts and would require quite a bit more of R coding. One is recalibrating the success threshold. Another is rather than fixing the allocation to control, what if we allow it to adapt in a very particular way? And thirdly, what if we introduce a little bit of reality, which is that endpoints are rarely immediate, and we often have to wait for an endpoint during which we've accrued other subjects. So there's a sort of a group of subjects at any one interim who've been enrolled, but we don't have data for. And what if we simulate that, and what effect does that have on RAR? At what point does it make RAR not worth having? So we'll start with this kind of simple RAR simulation, and my hope to, as I say, prove. Oh, I noticed there's a question. Oh, just thanks. Okay. I noticed. So I'm going to do this very simple RAR code, which I'll summarize here, and then we'll look at some simple simulation results. So in the in this R code, what I do is I'm going to equally space the interims throughout the trial. So we calculate the number per interim by taking the supplied maximum number of subjects and dividing it by the number of interims. And we set up an initial probability of allocation to each arm, which is simply 1 over the number of arms in the trial. So it's 1 to 1 to 1 to 1. So I'm not going to do a root K allocation to control. We could do that, but I've just kept it very simple. Then we get our first responses. So we use the rnormal function, and we simply take the number of subjects that are going to be recruited up to this interim, and we're going to multiply that by the fraction for each arm, the fraction of allocation, and we'll use the supplied mean and supplied standard deviation. So we add that to a vector of responses for that arm, and then we want to do our RAR. What I want to do is to allocate the arms in the proportion to which that arm appears to be the best, to have the maximum response. There's a paper that Kurt Vili produced some time ago on RAR, where he compared allocating according to the probability that the arms are better than control to the probability that the arm has the maximum response. And he showed that the latter is better. You get more adaptation. If you allocate to the arms in the proportion to which their probability that each individual arm is better than control, you might have 2 arms that have got some advantage over control, and the result is quite, you don't get allocated to almost evenly, even if one is a bit better than the other. Whereas if what we look at is the probability that the arms are actually the best of all the arms, then we get a much sharper distinction in the allocation. And that has better properties, because what we actually want to do is to find the arm with the best response. Now, so these simulations run quickly. I didn't want to drop out to do any Bayesian analysis using Stan or JAGs. So I've used frequentist statistics, although probably not in a very frequentist way. So what I've done is I then simply do a t-test between the active arms, so not comparing against control, but comparing against each other. So for each pair of arms, I do a t-test of their responses, testing whether the responses on the first arm is greater than the responses on the second arm. And then I construct a little matrix of the arms excluding control, and in it I store the inverse normal of the test statistic, so its probability that we're better than the first arm is better than the second arm. And then what I simply do is for each row, I calculate the product of all those probabilities, having assigned 1 to all the diagonals. And that becomes the probability of allocating to that arm. I just in case I renormalize things to make sure those probabilities all just still sum to 1. And you'll notice I'm avoiding updating the control arm. So the control arm keeps its 1 over k allocation throughout. And then we simply loop through stages 3 to 6 for how many interims we have. So the next update The number allocated to each arm is going to be different depending on it, because it's going to depend on its probability of allocation that we calculated down here at the end of the previous loop. And then at the very end, once we've completed all the interims, we do a t-test, but now each arm is compared to control. We select the arm with a minimum p-value, and we return the p-value, the index of the arm that was selected, the response on that arm, and the number of subjects allocated that arm. I don't know how visible this will be, but the code looks like this. That's just a single simulation, and then there's a simple function which loops over the number of simulations we want and accumulates the results. And when we run it, we get something like this. So here I've simulated with 4 arms, so that includes the control. My maximum trial size is 288. So that's a simple sample size calculation based on Bonferroni adjusted single-sided alpha of 0.05 with an expected difference of 1 point and a standard deviation of 2. And that says I need 72 per arm. And so I've got 4 arms, so a grand total of 188. So these are in this particular case, the responses I've simulated are a simple linear increasing, a response of 0 to 0.33, 0.67, and 1. Standard deviations at the endpoint of 2 for each arm. Here I'm simulating, well, I've called them interims, but that includes the final analysis. So this is actually 10 stages, 9 interims and 1 final. And my final alpha is the Bonferroni adjusted 0.05, and I've done 10,000 simulations. The first number is the number of simulations that were successful. They had an arm with a p-value that was less than 0.0166, and there was about 85%. This is the number of times each arm was successful. So you can see that the last arm, arm 3, the one with the larger response, response of 1 was the selected arm, the one with the minimum p-value, about 72% of the time. So out of those 85% of successes, there are actually only 72% of the time will be successful and pick the right arm. Then we've got the mean response on the arm when that was the arm, when the trial was successful and that was the arm selected. So you can see we've got quite a bit of inflation when one of these weaker arms was selected and successful, not surprisingly, because obviously they're only going to be the successful arm on those random occasions when they had a particularly random high response. On the arm we want selected and the arm we select most commonly, you can see the average estimate of the response is 1.037 compared to a truth of 1. So very, very small bias. And then lastly, you can see the number of subjects, the average number of subjects selected on allocated to each arm when it was the successful arm and the trial was successful. And again, you can see on our best arm, when that was successful and the trial was successful, we had on average 142 subjects. So almost half the overall allocation. So looking at a number of examples, so here's with 1 stage. With 1 stage, 2 stages, in other words, just 1 interim in the middle, 5 stages, so 4 equally spaced interims, and 10 stages, 9 equally spaced interims. you can see that the type 1 error decreases. So you can see there's our Bonferroni adjusted type 1 error, a little bit conservative in the fixed trial. And you can see that even with just one interim in the middle and then doing RAR, the type 1 error is significantly reduced. Actually, introducing 4 interims barely makes any difference. In fact, it's slightly gone up, although that's within simulation error. And then by the time we get to 9 interims, we've got a slight further reduction, but almost all the reduction occurs with just the 1 interim to adjust the randomization to target the arm that's performing the best. Now, this is under the null, so the bias, inevitably we've got some bias, but you'll notice even in the fixed trial we've got some bias because we're only looking at the response when the trial is successful. And interestingly, the bias when we're using RAR is less. And of course, we have this increase in the number of subjects on the selected arm. So we have this decreasing bias, and we have this increasing number assigned to the selected arm. So then I looked at 3 alternate scenarios. So the first one is just where one arm has the response of 1 and the other 2 are dunce, and they're effectively null. You can see that the power is increased compared to the fixed trial, but it's pretty constant irrespective of the number of interims. You can see our ability to pick the correct arm in the successful trials is better than with the fixed trial, or it's the same. In this example, picking the best arm is not hard. And so it's almost always picked. And again, looking at the bias on the arm, we can ignore these biases because these arms are picked less than 1% of the time. So this is the one that's significant. And again, you can see that in the RAR designs, the bias is less than the fixed design. So RAR has not increased bias, it's decreased bias. So it's decreased type 1 error, it's increased power, and it's decreased bias. And again, it's increased the number of subjects on the arm of interest quite considerably. If we make things a little tougher in terms of arm selection, we introduce a linearly increasing treatment effect. So treatment effect of 0.33, 0.67, and 1. I'm just doing pairwise comparisons, so there's no assumed ordering, there's no assumption of monotonicity, and this is supposed to reflect the situation where the arms aren't sort of increasing doses. There may be a treatment A, a treatment B, and a treatment that's maybe a C or combination of A plus B. So because we've got more effect across our arms, the power in the fixed trial has gone up. And the difference between that and the RAR is now quite a lot less. There's still a little bit of a power bump, but only 1 or 2 percentage points. The fixed trial picks the correct arm about just over 70% of the time, and RAR again is actually a little bit better at picking the arm, except with the 10 stages, the 9 interims, where this probability begins to fall off. So maybe we've got an interim that's so early, we've got a little bit of a risk now that that a random high on one of the other 2 arms distorts the subsequent allocation, and we miss the best arm. But it's still in only a couple of % of the simulations, and the actual probability of being successful in picking the right arm is still better than the fixed trial. And once again, the bias has decreased and the number of subjects on the arm of interest is increased. And the number of subjects on the arm of interest goes up the more interims we have. And then lastly, assuming there's actually quite a good treatment effect on all the arms, so on the worst arm, there's still a 0.5 response, on the second best 0.8 and the best 0.1. So we have two, if you like, fairly obvious effects of that. One is to increase the power. Again, the RAR is still a little bit better than the fixed, but it's only a couple of percentage points. Interestingly, the one interim RAR seems to be better than 4 or 9 interim RARs. The RARs are still better than the fixed trial at selecting the correct arm, although by the time we get to 9 interims, it's fallen back to almost being the same. And once again, the bias is decreasing and the number of subjects is increasing, not by quite so much, because it's obviously they're being spread across the different arms a bit more. So one of the things, the things that didn't surprise me was the reduction in type 1 error. I was surprised that without renormalizing, which we'll look at in a moment, we still also got improved power, but that's because we're allocating so many more subjects to the arm of interest. And I wasn't surprised that we were selecting the arm okay, and I was pleasantly surprised that it wasn't, we'd got a very small bias, additional bias, but actually we got less bias than the fixed trial, again, because we increased number of subjects. But what did surprise me was that the single interim RAR did so well. That I was expecting a little bit more of a progression of increasing power and increasing ability to select the arm and decreasing bias as the number of interims went up. And I was really surprised to see the single interim case perform so well. So I thought, well, maybe we ought to compare RAR to simple arm selection. What if we do a completely frequentist design? We have an interim halfway, we pick the best arm, and we carry on. And I'm going to use AdPlan to do that. It's going to do a p-value combination from the 2 stages, and it's going to use Bonferroni or Dunitz. So I've done both to compare them to adjust for the multiplicity of having 3 arms. And I'm comparing it to the two of the results you've already seen of my R simulation of RAR, one which is the fixed trial and the other where there's a similar interim at halfway. You can see that the RAR has reduced the time on error more. The Bonferroni is quite conservative in this scheme and is more conservative than the fixed trial. And the Dunitz corrects for that conservatism and gets us back to almost full 0.05. There's not much else interest in under these, unfortunately, from AdPlan, it doesn't, it reports a bias, but it doesn't do it conditional on arm selection. So I can't get biased results out of it that are comparable to the ones I've produced. And we can simply calculate what the sample size is on the selected arm. It's going to be 36 subjects from the first stage and 72 from the second. Also note that unlike my RAR that I've done so far, this will have equal allocation to control and the treatment arm, which does have a nice property, which it means we don't have to worry about any kind of time varying effect over the course of the trial. So just quickly looking at the arm selection, it's in particular the Dunitz has got better power than the RAR because it's a less conservative test. It had higher pipeline error. It's done a good job of picking the correct arm in the 0.01 case. Oops, sorry, a bit too fast there. In the other alternates, again, it has better power, but somewhat surprisingly, it's not doing such a good job of picking the arm once there's a little bit of competition between the active arms. So because it's making an absolute choice, whereas in the adaptive, in the RAR case, we may still be allocating to more than one treatment arm in the second stage. That means that even if we're even if we've got another arm that's looking as good, as long as we've kept we're still allocating to the true good arm, it's likely to show up at the end and still be there for for us to select it at the end. Whereas there's more of a risk of dropping the good arm in the fixed dose selection type design, and that's even more marked in the scenario where there's again a higher treatment effect. So it gets higher power, but even given that, it's the probability of having a successful drop and the right arm is lower than fixed design, and it's lower than the adaptive design. So what I wanted to do then was to look at some additional complexities in the RAR setting, and for that I'm going to turn to facts, because I wasn't going to start to make my R code sort of big and complicated. So the first thing was to just put this example into facts, which is I will show, just in case there's some of you not familiar with facts. This will be very quick, and I will switch the share. So here we've just started facts, and to stimulate a comparison of multiple arms against control, we want facts core, and our example has a continuous endpoint. So I'm going to start a facts core continuous design. So we said our sample size was 288. At the moment, we're simulating an almost immediate endpoint, so our set comes in 0.1 of a week. A higher response is an improvement. We have 3 treatment arms as well as control. We have these 4 scenarios. There's the null, there's the just one, there's the linear, and then there's all good. And if we set each one up, so the standard deviation was 2, and the response on all the arms was 0. In the just one case, the standard deviation was 2, and dose 3 had a response of 1. And I'll mark that as being the arm we would want to be selected. In the linear case, again, the standard deviation is 2. Now we've got a response on all the active arms, but again, the best one is here, and I'm going to mark that one as the one that I would want the design to pick. And then in the all good, again, the standard deviation is 2, and the response was 0.5, and one arm 0.8 on the next, and 1 on the best. So there's my 4 scenarios that I've been simulating. In fact, I always wanted to simulate accrual. Of course, in the fixed trial, that's almost immediate endpoint, that's not going to make a difference. But we're going to look at what happens if there's a time to an endpoint, and then the accrual is going to be important. I'm going to simply stick to the default of 5 per week, meaning that our total accrual time is about 57, 58 weeks. I'm not going to simulate any dropouts. And the only quantity of interest is a p-value. I haven't got any dropouts, so it doesn't really matter how I handle missingness. I'm going to do a Bonferroni adjustment. And then I want to use the p-value at the dose with the greatest probability of being the max. I don't need these. So that's all I'm interested in calculating for now. The design, we're just going to do pairwise. The Bayesian analysis will be used for calculating the probability of being the max. As much as a little bit, but it's not going to be used in the decision for success. So I'll use the pairwise comparison, the independent dose model. I could leave that at 10. I could make it a little bit less, say 4. I leave the mean at 0, which is what we're simulating for the control arm. And 4 is twice the standard deviation at the endpoint. So my prior has a weight of about 1/4 of an observation. And I set up the prior for the estimation of the standard deviation of the endpoint. I center it correctly on the expected value 2, but I just give it a weight of 1. So it's a fairly non-informative distribution. The final estimate will be dominated by the observed data. We don't want any separate frequentist. And if we do the fixed trial, then we're just going to leave the allocation 1-to-1. But if we want to do an adaptive trial, we have to enable adaptive features. We say we want to do adaptive allocation. We leave the initial allocation ratio as equal. And then I say I want to target the arm with the greatest probability of the maximum. We'll weight it just by its probability, and we'll give it a relative weight of 1. That doesn't really matter because I'm not going to give it any additional targets. And then at the moment, what we're doing is we're fixing the allocation for the control arm, and I'm going to say it's allocated kind of an allocation of 4 out of a block of 16, so it retains a 1/4 allocation. And then we could have our first interim halfway through, based on the number of subjects complete. So the total sample size was 288, so half information is 144 subjects complete. And then we can have a probability of success based on the p-value being less than 0.05, because it's going to be adjusted. It's going to have its Bonferroni multiplication. And that gives us our scenarios. And we'll let FACS go and simulate 10,000 of each scenario to give us a fairly good estimate of the operating characteristics. As you can see, it's a fairly quick, simple design. So FACS can, and with only 2 analyses, the interim and the final, so FACS can get through them pretty quickly. So we should be there. A moment now. Now, what FACS has been doing is it's been doing their 10,000 simulations in packets of 1,000 spread across the different cores on the laptop. Although it's actually not saying for 40,000 complete, the point we're actually at is where it's now aggregating the results, aggregating these packets, putting them together, and calculating the summary values. So here they come. So you can see here in the null, there's our type 1 error reduction. It's 0.0336. Stitching together the next set of results. So what we're going to look at is principally this first column here, the proportion of late success. We haven't got any early success. I haven't set any early success criteria up, so all the trials are going to go to the end. So we really need to consider late success. So for the null scenario, this will correspond to type 1 error, and for the others, of course, this will correspond to power. And now we have our full set of results. So you can see we've got 88%, 86%, 87, 88% power in our three different alternate scenarios. And then way on the other side, we've got the proportion of simulations which was successful and selected the correct arm. So if you recall, I was checking should succeed the correct arms in the different scenarios. The default is the arm selected will be the arm with the highest probability of the maximum. And what it's checking is in these, out of all the simulations, if they're successful, was the arm that had the highest probability of being the maximum one flagged as correct. So here I've got FACS is calculating for me how often we're selecting the correct arm. So going back to the slides, if I repeat that, so I did simulations in FACS with no adaptation, so corresponding to the fixed trial, and then with 5 and 10 stages. And this basically just shows that we've got, as we would hope, very, very similar results to that little R simulation. So we've got a starting point of a FACS design, which we know without any elaboration behaves like the R code does, and then we'll see what the effect of the changes are. But before we do that, we'll just look at one of the things that FACS has is some graphs that can show us what's going on in individual simulations. So we can actually sort of dive in and see how this RAR is kind of working in practice. So here's just simply the first simulation where this black line shows the true scenario we're simulating from. So this is the one where there's a response of 1 on dose 3, the response of 0 elsewhere. This first graph is from the first and only interim, and then the second graph is the final analysis. The dots you can see is the raw data for the dark brown, and then the green is the estimates actually from the Bayesian analysis. And what you can see here is that in this simulation, the data on dose 1, just from the random sampling, is actually considerably higher than the mean that we're simulating from. So that's looking quite good. But of course, dose 3 is looking even better. And you can see at the end, we allocated very few additional subjects to dose 1, despite its looking quite promising. And almost all the available additional subjects went on dose 3. And of course, we continue to allocate to control. And this of course, is would have been quite different if we'd been allocating in proportion to the probability that the arm was better than control. And if that we'd been using that as the target, then dose 1 would have got a considerably higher chunk of allocation, and dose 3 correspondingly less. So here's one from the scenario where we've got a linear increase in response, and once again we've got a high on dose 1, a little bit more on dose 2, and dose 3 is also relatively high compared to the truth, and we have a very similar effect, but just a little bit more allocation to dose 1 than before. And then here's one where we've got more of a response in all the arms. Once again, dose 1 is high, and again we've got a little bit more allocation to dose 1, a little bit less to dose 3 as a consequence. But even with that relatively small difference in the measured response, we still overwhelmingly allocate to dose 3 compared to dose 1. If we have 5 allocations, 5 stages, 4 interims, here's an example from that last scenario where there's a response on all the arms, and you can see things evolve more measured, but the eventual outcome is somewhat the same, although we've stopped allocating to dose 1 and dose 2 earlier, so their allocation is actually somewhat less at the end. So here, the y-axis is 175, whereas in these previous examples, it was only 120, 125. So the greater number of interims in this case has allowed us to allocate even more to the better arm, which we also saw in the operating characteristics from the R simulations. It can go wrong. So here we've got a really random low in the data on dose 3. Dose 1 is having some effect because it's simulated with some effect, and it's actually a little bit higher than that. As we allocate, dose 1 regresses a little bit towards its mean, then it goes above and we allocate even more to it. And in the end, we've allocated mainly to doses 1 and 2. And you can see, in fact, dose 2 will be the one that will be selected at the end of the trial rather than dose 1. So it's wrong, but it's not as wrong as it would have been if we just made a dose selection at some point, say halfway-ish here. But equally, you can see that the algorithm is doing what we expected, and if we just looked at that data and didn't know what the truth was, we'd probably be very happy with that allocation. We're indeed pursuing the better arm, and but we're hedging our bet with a certain amount of allocation to the second arm, because it's second best arm, because in this case it's quite close, which in the end kind of saves us, or not quite saves us, but means it's not quite as bad as it would have been. In order to compare against the arm selection and the Dullits, which had that high power, what we need to do is to renormalize the success criteria. So again, we're going to use a nice graph in facts. Let me just show this for real. So here we've got this, we've reduced, suppressed type 1 error lower than we need to. And we're thinking this is, I'm using p-values, I'm thinking of this as being a sort of a phase 2 setting. So hence the alpha type 1 error I'm targeting is 0.05, not 0.025. And we've got a graph called Explore Final Success Criteria, which plots how many of the simulations would have been successful at if you like, every possible threshold value. So here, what we're testing is a p-value. So the the numbers of successes are lower, the lower the threshold, not surprisingly. And if our threshold were 1, then pretty much everything would be a success. It also allows us to set a target success rate, 0.05, and it tells us at the bottom what the threshold should be if that's what I wanted to achieve. And in this case, it tells me I could adjust the test of the p-value, the Bonferroni adjusted p-value at the dose with the maximum response. I could set that level to 0.0751, and I would have no more than 0.05 time on error. Now, obviously, this is based only on 10,000 simulations. If we were doing this for real, we'd probably use 100,000. So I was a little bit conservative in taking those limits. I always rounded them down. So I simply went to the success futility criteria and modified this threshold to readjust, still keeping the time on error below 0.05, but getting closer to 0.05. If we see what that did. So, and just a note, this practice of renormalization is actually accepted by the FDA. It has actually been, it was accepted on one of the pilot trials, designs in their complex innovative designs initiative. One of those had RAR, and they were happy that the threshold was adjusted to reduce the time on error inflation back up to the target level using simulation. But this is the effect of the power. So each of these colored lines corresponds to one of the designs. So we've got the NR, the fixed design, this with the lowest power, and that doesn't change in the second graph. The two-stage is the orange line. And there's the Dunnits in there. Also doesn't move. Oh yes, that's the best line here. So in this, before we re-normalize, the Dunnits and the no selection has got the highest power. Once we recalibrate the FACS adaptive designs, the fixed one, the blue line doesn't move either, but the other three, as you can see, all shoot up. So they're now much more comparable to the Dunnits. And similarly, although it's harder to see here because the lines are closer together, but here we're looking at the probability of selecting the correct arm. You can see that the Dunnits is although it does well on if there's just one really good arm and everything else is null, on the others it's the worst at selecting, and the FACS RARs all move up somewhat when we do the renormalization to increase the power. The other thing we can do is change the allocation to control. Now, we've started off using the fixed allocation, but one of the options in FACS is to leave the control allocation control adaptive. Now, when it does that, it doesn't allocate in the proportion to which it's the maximum. That would be that's a bad design choice. What it does is it allocates to the control in the same proportion as the active arm with the maximum allocation. So it matches the maximum probability of allocation across the active arms. And that results in approximately a one-to-one allocation between the control and the selected arm. If you've got multiple interims, obviously the arm which is the maximum might change, which is why it won't necessarily be one-to-one. But if it was constant and one arm was the best over the interims, then you would end up with a one-to-one allocation. This gives you a higher power because you've got more equal assignment to the two arms you're comparing. It also means that approximately over time, the allocation is equal. So if you've got a risk, if your trial's quite long running, and there's some risk of some sort of underlying change in the response over time, it's independent of the arms, then this removes the bias, because you by maintaining a one-to-one allocation, the effect will impact the control and the selected arm almost equally. The downside is you'll have fewer subjects on the experimental arm, and quite often in a phase 2 setting, having more data on your trial drug for all those additional endpoints and safety data and so on might be very desirable. And if the phase 2 is going to execute quite quickly, you might think there's actually not the risk of a time varying component, and it might already be powered sufficiently highly, particularly because we can have a higher than 0.025 time and error, and you might actually prefer the maximizing the experimental data on the selected arm, and also use the more fixed allocation to control. So it's up to you which path you go by. But when we do that and renormalize, you can see now that the time of error is about the same. The power is now actually slightly better than the Dunnett's dose selection in all these cases, and of course we're selecting we've got better chances of selecting the arm than the Dunnett's did. But we still have this situation that there's not a lot of difference between doing 1 interim in RAR and doing 9, which, yeah, as I say, still surprised me. So that's showing the same data, but graphically. So you've got the fixed trial they're doing poorly, and you've got the FACS trials doing the best up at the top. You've got a slight advantage of the 10 stage trial compared to the 5 or the 1. So lastly, and I realize I'm just overrunning my time slightly, I want to look at the effect of delay, because this is going to make things actually quite a lot more realistic. And also it kind of addresses the question, well, just how, with some delay, is RAR still relevant? This time to endpoint is frequently absent from frequentist statistical software. But of course, having some sort of time to endpoint is much more common in trials than having an instantaneous endpoint. And it's easy to simulate in FACS. So in our simple example, we've got a sample size of 288 and an mean accrual of 5 per week. And so accrual is taking 57 to 58 weeks on average. And kind of what's important is what's the proportion of the time of the time to endpoint as a proportion of the enrollment time. So if we just think of it in terms of percentage times, we could kind of generalize what we're going to see in these examples. Now, first obvious point, if the time to endpoint as a percentage of the enrollment time is greater than 100%, then you can't adapt to the final endpoint at all. You'd have no data. And the classic example of that is in the obesity trial with the 12-month endpoint, sustained weight loss, and you'd probably enroll the trial in a month. So there's absolutely no chance of being adaptive at all. But let's look at some intermediate cases. So maybe we've got, in our setup, it would be something like a 3-month endpoint, 20% of the accrual time. So 12 weeks with 5 subjects per week, we'd have enrolled about 60 subjects at any point that were enrolled, but we didn't have any data for. So instead of 288 subjects we can adapt, we've only got 228. So if we did a 1 interim trial, to do it halfway through, its interim would now be at 114 subjects rather than 144. If we did 4 interims, they would be at 45, 90, 135, and 180 subjects complete. And similarly, if we had 9 interims. But we can also look at what if the time is even longer? What it's 33% of the accrual? That would be 19 weeks, and we'd have 95 subjects enrolled, but not complete. So we now only have 193 subjects we can adapt to. So halfway through the trial is now 96 complete subjects, and similarly reduced for the others. And then finally, we'll say, well, what if the endpoint is 50% of the accrual? So halfway through we're going to be halfway through accrual before we've got our single first endpoint. So we've got 144 subjects enrolled, but not complete. So our halfway point is now 72 complete, although that would actually be 216 subjects enrolled. So we've got 7 out of which we'll only have information on 72, with a further 72 still to enroll. So we've got that's our half information, with half, the equivalent half enrollment still to carry on. And then similarly, the shifted the other interim points to the 4 interims and 9 interims. And there's got a lot of lines on this, but so basically here is our single fixed stage, power and probability of selecting the right arm. So all the adaptive trials are still better than the fixed trial, even the ones where there's a 50% delay. Now, the 50% delay are these dark ones, the purple, the blue, and the brown, the black. So it's these down here. These will be the 50% delays, then the 30%, and the 20% will have the highest power, and similarly for selecting the correct arm. And the other thing that we see, it's probably clearer with the 20%, the blue, the orange, green. We have, there's actually a little bit more benefit in having more interims now with this delay. Whereas previously having one interim looked the same as, or even sometimes better than having multiple interims. Now there's a little bit more of an advantage of having the additional interims, but I grant you not much. So if you wanted to have a look at this yourselves, just to emphasize, FACS is freely to use for academic and government institutions. If you're a commercial organization and you'd like to evaluate FACS, you can get an evaluation license for several months and giving you full access to FACS. If you're interested, just drop me an email, Tom@Berry Consultants. You can also email me if you'd just like to be on our regular webinar emailing list.
Just have one question in the chat, Tom.
Thank you. So yes, so there was a question, does the FDA accept the renormalization of the p-value threshold due to type 1 error deflation during RAR? Yes, they certainly did in this example in the CID project that they ran. If you look up the CID project page on the FDA website, look for the example that used RAR, and hopefully there's some reference to the reduction of the type 1 error threshold. Okay, thank you very much, and hopefully we'll see you next month when we'll have another webinar.